Hello, good evening, everyone. We'll be continuing with a class on endocrine changes in pregnancy, and this is the part 4 of the chapter. So, let's begin. This part covers the endocrinology of pregnancy and parturition, particularly the parturition that is during delivery and labor, and the fourth trimester of pregnancy that is the immediate postpartum hormonal changes during after delivery. So, as we know, the progesterone is the most important hormone in pregnancy. Progesterone is essential for maintaining the pregnancy. Progesterone is produced by the corpus luteum in the early part of the pregnancy, and this progesterone is later on produced by the placenta. Progesterone is responsible for maintaining uterine quiescence, that means stability of the uterus. And how does it maintain the uterine quiescence? It maintains the uterine quiescence by limiting prostaglandin production. Prostaglandin, as we see, are responsible for inducing labor. Progesterone also reduces oxytocin and prostaglandin receptor expression in the uterus, and progesterone also regulates ion channels in the uterine contraction machinery. Progesterone usage has been shown to reduce the preterm birth in clinical trials. Intravaginal progesterone is very, very effective in high risk pregnancies, for example, those with short cervix. And intramuscular progesterone, on the other hand, has inconsistent results. What about the role of estrogen in pregnancy? Estrogen enhances LDL uptake in the syncytotrophoblast for steroid production. Estrogen also increases uterine blood flow for nutrient and gas exchange. And estrogen causes mammary tissue hypertrophy in preparation for lactation. Now, before the labor, there is a functional progesterone withdrawal. Despite no drop in the progesterone level, there is a functional withdrawal of the progesterone. Now, how does this occur? Basically, there are two isoforms of progesterone receptor A and progesterone receptor B. Progesterone B is isoform. It is responsible for maintaining the uterine quiescence, whereas progesterone A isoform it leads to labor onset, and progesterone isoform A represses progesterone isoform B, and this in turn leads to labor onset. It's a very important question that labor is associated with an increase in progesterone isoform A relative to progesterone isoform B. So remember that during labor, there is a rise in the progesterone isoform A, whereas throughout the pregnancy, the uterine quiescence is maintained by the progesterone isoform B. Now, what is the role of prostaglandins during labor? There is basically a compartmentalized production of prostaglandins in the uterus. Prostaglandin E2 is produced in the fetal membranes. Prostaglandin F2 alpha is produced in the decidua, and prostacyclin 2 is produced, on the other hand, in the myometrium. This prostaglandin E2 and prostacyclin 2 they inhibit uterine activity, while prostaglandin F2 alpha promote uterine contractions. What are the clinical uses of prostaglandins? Procontractile prostaglandins are used clinically. For example, prostaglandin E1 is used for cervical ripening and labor induction. Remember, prostaglandin E1 used for cervical ripening and labor induction, and prostaglandin F2 alpha, which is responsible for causing uterine contraction, is used as a treatment for postpartum hemorrhage. Prostaglandin inhibitors like indomethacin are also used to delay preterm labor. Now, what is the role of oxytocin in parturition and labor? Uh, Oxytocin is produced by the hypothalamus and stored in the posterior pituitary. Placenta also acts as a significant oxytocin reservoir. Oxytocin binds to the G protein coupled receptors in the uterus. The receptor levels of oxytocin increase 100 to 300 fold during pregnancy, especially in the fundus. The clinical uses of oxytocin are induction of labor, treatment of postpartum hemorrhage due to uterine atony, and oxytocin receptors increase the sensitivity of the myometrium. However, they may not initiate labor directly. Now, as we know that the placental hormones can also be used in the screening of various genetic diseases and overall pregnancy outcome. So this question is very important. So just look at this question. The following biochemical profile in pregnancy suggests which genetic syndrome? The biochemical profile is suggestive of elevated human chorionic gonadotropin, low PAP-A, which is placental associated protein A, and low alpha fetoprotein. The options are trisomy 13, trisomy 18, Down syndrome, or Turner syndrome. Yes, the answer is Down syndrome. So the placental hormones can be used in genetic screening of various genetic diseases as well as also in predicting pregnancy outcome. Although there is a very frequent use of cell-free DNA screening, particularly the NIPT test, which is emerging as the primary method for prenatal aneuploidy screening, however, biochemical screening has been historically used and still very much relevant. Biochemical screening has always relied upon the placental hormones and proteins, and the various alterations in the biochemical screening of the hormones, they have predicted various genetic diseases as well as also in the pregnancy outcome. But nowadays it is we are seeing that it is frequently being replaced by the NIPT test. So this table from Williams is very important. This is the maternal serum analyte pattern for genetic diseases. You may get a question. This is very commonly asked in various entrance exams. So you may get a question in your entrance exams as well as also in your exit exams. So as we can see in Down syndrome, there is, which was asked in the question, there is low level of PAP-A. There is increased HCG. There is less alpha fetoprotein. There is decreased unconjugated estriol, and there is increase inhibin A. So two biochemical parameters are increase in Down syndrome, that is HCG and inhibin A, whereas the other parameters like PAP-A, alpha fetoprotein, and unconjugated estriol are decreased. On the other hand, in trisomy 18, the PAP-A, HCG, alpha fetoprotein, and unconjugated estriol are reduced. In trisomy 13, particularly PAP-A and HCG levels are decreased. In Smith-Lamley-Opitz syndrome, which is a placental sulfatase deficiency, alpha fetoprotein and unconjugated estriol is reduced. Other levels are not affected. Turner syndrome, 45XO without hydrops, all the factors that is PAP-A, HCG, alpha fetoprotein, and unconjugated estriol are reduced. Turner syndrome with hydrops, again, this PAP-A level is decreased, but HCG is increased, alpha fetoprotein decrease, unconjugated estriol decrease, and inhibin A is increased. And placental sulfatase deficiency, only there is a decrease in the unconjugated estriol, while the other biochemical parameters are unaffected. So this table is very, very important. You have to, understand this table, and you have to, remember the pattern of various biochemical parameters, which help in detection of various genetic diseases. So this is the text. So human chorionic gonadotropin levels, they are elevated in Down syndrome and they are low in trisomy 18. Pregnancy-associated plasma protein A, that is the PAP-A level, they are reduced in common aneuploidies like trisomy 13, 18 in Down syndrome. This first trimester screening, in the first trimester, we screen usually the HCG and the PAP-A and the nuchal translucency measurement. And this first trimester screening gives us an idea about the Down syndrome and trisomy 13 and 18. And there are also pregnancy outcomes can also be predicted with the help of all these biochemical parameters, the hormones which are produced by the placenta. So if the PAP-A level is very low, if it is less than 0.42 MOM, then there is increased risk of preeclampsia, growth restriction, fetal demise, and preterm birth. If the free HCG is also very, very low, if it is less than 0.021, there is again increased risk of growth restriction, fetal demise. If the alpha fetoprotein is very high, which is more than 2 MOM, then there is increased risk of growth restriction, fetal demise, and preterm birth. If the HCG level is more than 2 MOM, again there is high risk of preeclampsia and fetal demise. If unconjugated estriol is less than 0.5 MOM, there is increased risk of growth restriction and fetal demise. If inhibin A is more than 2 MOM, there is increased risk of preeclampsia, growth restriction, fetal demise, and preterm birth. So again, this table is also very, very important. So please go through this table. You have to remember these MOM values, and you should also understand what are the various predictive patterns of these MOM values. The second trimester biochemical screening, which is usually done at 18 to 20 weeks. So this includes biochemical parameters like HCG, estriol, inhibin A, and alpha fetoprotein. Estriol again is lower in Down syndrome and trisomy 13 and 18. Inhibin A is high in Down syndrome. Okay, inhibin A is high in Down syndrome, and HCZ is also high in Down syndrome. And alpha fetoprotein is particularly produced by the fetus, and it is useful for detecting structural abnormalities like neural tube defects. Uh, Now, what is the association of placental hormones with pregnancy complications? The low estriol level is indicative of placental sulfatase deficiency or Smith-Lamley-Opitz syndrome. The elevated alpha fetoprotein and inhibin A, they are linked with fetal growth disturbances in intrauterine fetal death, and alpha fetoprotein is particularly essential in assessing the neural tube defects. The low PAP-A is associated with growth restriction, stillbirth, preterm birth, and preeclampsia. The low PAP in the first trimester predicts high risk for growth restriction and preeclampsia, and increased inhibin A in the second trimester is also correlated with preeclampsia risk. So the key takeaways from these slides is that placental hormones play a very crucial role in genetic screening for aneuploidies. Despite the rise of cell-free DNA screening, that is NIPT test, biochemical markers still remain important for identifying structural abnormalities and various genetic diseases, and also for predicting pregnancy complications. Now, lastly, coming to the fourth trimester and the parental brain. So, what is the fourth trimester? The fourth trimester refers to the immediate postpartum period. So, after delivery, there is an abrupt transition with new endocrine, metabolic, psychological, and socio-cultural challenges. Physiological adaptations prepare the maternal brain for lactation, caregiving of the newborn. There is a tremendous hormonal change post delivery. There is something which is known as postpartum endocrine shifts. So, there is a sharp decline in the placental hormone levels post delivery, and the neuroendocrine axis responds to the withdrawal of pregnancy hormones. The lactation and newborn care triggers maternal adaptations different from pregnancy, and feeding and sleeping patterns of the infant can also influence maternal physiology. There may be some long term health implications of this fourth trimester. Pregnancy, in fact, imprints permanent physiological changes on both the mother and the child. The acute impacts may be felt on lactation, maternal metabolism, and stress responses. The long term impact may be certain conditions in pregnancy like gestational diabetes and preeclampsia. They elevate the maternal risk for future health issues. An immediate postpartum period therefore presents opportunities for interventions to improve the maternal health outcome. Now, as we know, there are many challenges of the fourth trimester, both endocrine and sociocultural challenges. Some individuals they struggle to adapt to the postpartum hormonal and sociocultural challenges. Inequities in birth experiences may exacerbate these challenges. And there are psychological aspects also. There are a lot of psychological changes during the postpartum period. There's something which is known as a parental brain. In the brain also there is adjustment to care for the infant, and this is driven by neuroendocrine changes. Postpartum psychiatric disorders like depression can also primarily affect the gestational parent. The long term implications of pregnancy complications can be gestational diabetes, which increases the risk of developing permanent type 2 diabetes post pregnancy. There is, in fact, 30 to 50% risk of developing permanent type 2 diabetes post pregnancy if the patient does not undergo lifestyle changes and does not take proper care. Gestational hypertension is also associated with higher risk of future cardiovascular diseases. Postpartum depression can heighten the risk of future psychiatric conditions and endocrine disorders. Now, there is an important role of the healthcare provider during the postpartum period. The team approach, that is a multidisciplinary collaboration, is essential to improve the health outcome. Healthcare providers must address both medical and psychiatric complications like postpartum depression, risk assessment and screening. So, the healthcare provider should aim at focusing on the screening and surveillance during and after pregnancy for at risk individuals, and interventions should be tailored to individual needs to prevent long term health issues. Thank you. So, as I said, this postpartum period is very, very important. There is a lot of endocrine changes, metabolic changes, as well as psychiatric changes. And during this postpartum period, we need to be supportive to the parents, particularly the mother. Her body adapts for caring the newborn, and a supportive environment is required for nurturing both the mother as well as the baby. Thank you very much.